Okay, hello everybody. It's great to be here. Thank you, Louise, and the Summit Committee for inviting me to be part of this every year. It's not just a privilege, it's an honor. And I would like to excuse from my voice up front. It is the blessing of the season, but I'm here nonetheless. So the Summit Committee asked me, and it's the green, right? Yeah. Asked me to speak about three things in particular. And I'll be touching upon the social determinants of health. I will describe how they impact access to care, and I will share my perspectives on value-based healthcare. And since we are all a bit delirious after lunch, and I need to redirect the blood flow from the tummies to the brain, I'm going to start with a pop quiz. And I won't put anybody on the spot. We'll just take votes. So let's read through this question. In the Greater Toronto Area, 1 in every 20 residents has difficulty making ends meet. B, 1 in every 50, and C, 1 in every 7. So let's just have a show of hands. Is it A, 1 in every 20? 1 in every 50? 1 in every 7? It really is 1 in every 7. And that's an astounding number. And you may be sitting there thinking, well, what does having difficulty making ends meet got to do with health? And the truth is it has a lot to do with health, probably more so than anything else. And I'll spend the next couple of minutes unpacking this for you. So these are the three ways in which access to resources typically shapes health outcomes. Number one, by shaping the prerequisites for health. Do you have a warm place to live? Do you have enough food to eat? And I think those are pretty logical, right? But access to resources also impacts day-to-day stress. What is it like to live under conditions of constant deprivation and continuous activation of the stress response? Well, the body's biological mechanism is going to stay on continuously and impact the body's health system in a very simplistic way. And third, by limiting opportunities to make choices. Can I choose to buy the fresh fruits in the market? Can I choose the gym membership around the block? Can I even choose the phone plan that's going to allow me to dial my mom and release my stress? Well, opportunity to access resources shapes health in a multitude of ways. And if we look at this rainbow model, this describes the social determinants of health. And I, me, you, everybody, is just really the little red core of this rainbow. And our health is impacted by so many other things that layer upon ourselves. Is it the community where we live? Is it the place where we work? Is it the community where our housing is? How are my conditions when I go to pray? What is it like when my kids play? And eventually, all of these things are shaped by the social and public policies of where we live. And how important are they in shaping health outcomes? Well, take a look at this infographic from the Canadian Medical Association. 50% of our health is shaped by the social determinants of health. And whereas that's not my talk today is about the 25% that's shaped by access to healthcare. We may think, well, in Canada, we have Canadian Medicare through the Canada Health Act, which I know Louise described in great detail this morning. So, really, we have a publicly funded health system. What are we even talking about when it's access? We're not across the border in the United States, right? Why are we going to spend time even talking about this? So I thought I'd start by looking up the definition of access in the dictionary. And I just went online, looked at the Merriam-Webster dictionary, and this is what I found. So access is described as the ability to use, enter, or get near. And these are two very different concepts, right? So am I entering a place or am I using a place? And in healthcare, this is really important. And you can have the opportunity to get into a place, but you actually get in the door and use it. And that is the question that I'm going to try and answer for you today. So how do we describe access in healthcare? It's the use of personal health services to achieve the best possible health outcomes. So we have health services, thank you to our Canada Health Act. Are we able to use it? And are we able to achieve the best possible health outcomes? So really, it's three different things: entry, utilization, and outcomes. And let's take an example to understand utilization here. In Canada, we have extremely high rates of mortality related to lung cancer. And that is because tumors are found at a pretty advanced stage, when the tumor has already metastasized to the body and the chances for cure are pretty low. If we can find tumors at an early stage, when they're amenable to treatment, the chances for curative therapy are extremely high. Now, this is very promising to reduce lung cancer mortality. And now we have a health innovation that allows us to do just that. This machine uses low-dose CT scan to diagnose early-stage lung cancers. Very exciting. The premise is that there will be this encounter in the clinic where a physician is going to identify a patient who could be at a high risk of getting lung cancer and offer them the screening test, and the patient is going to say, oh yes, I absolutely want to do this screening test and improve my chances to live. Now, I'm not going to talk about how the physicians generally look. That's another topic for another day. But I will talk to you about how the patients tend to look. And there's a huge spectrum. Now, just taking these fictitious examples, but the reality wouldn't be far from what I'm about to share. If we look at John on one side, he's an executive working in his office. He can take the day off to go visit his physician. He's going to take the day off when he goes for a CT scan, and he's going to follow through on all of the recommendations that his doctors provide. He is the one who's going to find his tumor early, and he is the one that's going to survive lung cancer if he ever had one. David, my friend, on the other hand, doesn't even know what he's going to eat tonight. He's had chronic cough for a long time. If the doctor even mentions a screening test to him, the first thing on his mind is going to be, do you even know what my problems are? You're talking about me saving my life a couple of years from now, and I don't know what's going to happen tomorrow. And the truth is that utilization is impacted by so many different things. Age, gender, ethnicity, disability, resources such as income, food security, homelessness. And, well, we can talk about utilization, but do outcomes differ based on utilization? And again, let's just go back to lung cancer for a minute. And yes, outcomes do differ based on utilization. If we take a look at this graph, the bottom line represents the richest Canadians, and the top line takes a look at the poorest Canadians. And ever since forever, until to date, if you are poor, you are less likely to survive lung cancer. And I've just shared with you a couple of reasons why that may be the case. So where do we go from here, really? And what are the implications for value-based healthcare? Well, these are just a couple of my perspectives. And I take the definition of value from Porter, which is outcomes that matter to patients over the cost throughout the patient journey. And a general word of caution that I have is that when we know 50% of health outcomes are driven by the social determinants of health, we're putting a lot of emphasis on the healthcare system if we assume that just the healthcare system is going to drive health outcomes for the whole population. That in itself is a flawed assumption. So what does that mean when we consider value through the healthcare system? I would say, specifically because we are talking about cost, I'm going to put it in economic terms. If you want a return on investment, for every dollar you put into the healthcare system, you need to put at least $1 into social spending, if not $2, if you're going to drive total value for the population. And you really need a strengthened base of social services upon which to deliver health services if you are going to achieve that value at all. But my closing remark is really based on the appropriate integration of patient-identified priorities. And we've spoken a little bit about patient engagement. And what I would really like to say to everybody who's here right now, and for all of those who are patients or caregivers or funders or decision makers, when you have a seat at the table for an advisory committee or you're part of a board, use your voice to represent the voices that are not heard. The voices that are never going to make it to that seat at the table. It is our responsibility to share that voice if we have the privilege of being at that table. And if at all, we can find participatory ways of getting their voices at the table, then make every effort to be able to do so. That really is the closing point that I'd like to make. I will leave you with this image from United Way, which really shows the immense issue that we have when it comes to homelessness and housing insecurity. This tower, called the Unignorable Tower, represents the mammoth infrastructure we would need to house the 120,000 Canadians in the GTA currently facing housing insecurity. So really, what conversations do we need to be having? And where do we need to drive that value from? I'd be happy to take any questions now. Thank you.
Any questions or comments?
Hi, Ambreen. Thank you so much. I guess one of the things that concerns me is, I mentioned this morning, I believe everybody works on the punishment or reward system to do anything. And if I look at politicians, which I try not to, well, I actually do a lot, they just want to get reelected, and they want people with lots of money to fund their campaigns. So the people that you and I are talking about here and worrying about are not those people. So how do we, what's the risk and reward that we could argue to both the politicians and the bureaucrats for making these social changes? And I'd like to give an example, and maybe it's an example that you might know about. I read about 3 weeks ago that the University Health Network has put aside a plot of land by their hospital to house people who would otherwise spend days and days waiting in their emergency rooms because they realized it was cheaper to build them somewhere to stay than to have them sitting in their emergency rooms. So, I mean, I can see what the reward there was, but how do we get more of that kind of good behavior, and particularly at the political level?
Well, I think from that example in particular, they came to this conclusion that having people who are homeless meant that they kept using the emergency department, and the eventual cost of treating people who are homeless and returning to the emergency department, it's all about the return on investment, I guess, right? So they're extremely costly high-end users. So if we are able to house them, can we give them a safe place to stay so that overall improvement in their access to resources and health will reduce their consumption of the health system? Now, I think that's a great strategy, but I do think it's still one step removed. I think the question that someone really needs to put out there is, well, why are they homeless in the first place? Which cracks did they fall through? Where did our system fail them? They're not homeless because they choose to be. And I've spent a lot of time talking to patients who are homeless. No one chooses to be in that position. They're in that position quite simply because they fell through some cracks. So where do we need to seal those cracks so they're never homeless to begin with? It's what I call a Band-Aid solution, where housing is important. It's extremely important. But let's get to the policies that are allowing people to be homeless in the first place. And I think unless we confront politicians with those kind of tough questions, and particularly I would say I'm very privileged in the sense that I can stand up and say what I think and feel, and I'm not afraid of any repercussions to that. So unless we have more people in places of power that are able to speak the truth and question some assumptions that have been just left behind. Let's put it under the rug. Let's build a housing tower, and let's not question why we'll need another 2 in another 3 decades, right? We're not really addressing the root problem. So we need to understand solutions and identify which are the tough questions that need to be asked.
I don't know if this is a question, more a comment. I completely agree with what you're saying. My issue is that you have to start somewhere, and Band-Aids are important.
Absolutely.
And sometimes before going into surgery, you need to stop the bleeding. So the way I see those things is, and it translates to everything. My lens is mental health, but it translates to everything. You have downstream intervention, that's like your critical issue you have to solve right now, homeless in the street using ER. And then you have your upstream intervention, which is prevention. Don't let them get homeless. You have to attack both of them at the same time.
I agree.
Because you can't go upstream and let people die, and you cannot worry about the ones that are here dying and let these people get to the same place in 1 or 2 years. But what I see as one of the issues is that we have the same people doing both, and you can't. There is no sustainability. We have to engage people. We need people that are gonna worry about the people that are drowning now and make a human change and get them out of the water. And then you need other people that are gonna be up there building the bridge. But right now we have the same agencies doing both and getting burnt out and having resources, having to share resources for both, and obviously they go here because this is the urgent solution. So for me, there has to be a change of thinking. There has to be we have to understand that they're both equally important. I don't know in the rest of health. In mental health, I think it's 1% or 2% of the resources are dedicated to prevention. The rest are dedicated. We have to change that. We have to do it gradually, but you have to change it. And it can't be one or the other. You cannot just grab resources from here, put them here. No, you have to create new resources for intervention. You have to create new people. Get innovators there and get the people that are doing the day-to-day. Don't take from them. They need that. But I feel that is the thinking that has to shift. So, sorry, because it wasn't a question.
No, I appreciate That was very well said. I think the fact that you made, the point that you made, which was we do need upstream and downstream interventions to happen in parallel, I think that's extremely important. I by no means mean to undermine the downstream interventions. That's where I spend a lot of my time working. But even within the same agency, whenever we spend our time either upstream or downstream, we tend to get so siloed and so focused on our own work that we lose sight of the big picture. And I think really the aim of my talk is to remind people that wherever you're working, don't lose sight of the elephant in the room, and just remember that it's there, and wherever you're working, it's important, but don't forget on what needs to be done overall, and that we're one piece of the puzzle wherever we are. Thank you.